Good morning. This is next, okay. So we would like to thank the SAGES Program Committee for this opportunity to present our data here today. Okay. We have no relevant disclosures. Cholecystectomy is one of the most commonly performed procedures, as there's nearly 1 million cholecystectomies performed in the United States alone in 2014. However, in the unstable patient, percutaneous cholecystostomy tube placement is often the management of severe acute cholecystitis. PCT placement can later be reversed and cholecystectomy be performed. However, the rate of cholecystostomy for all PCT placement is not well characterized on larger scale data, as only single institution studies with a small number of patients exist. For example, in 2006, Paran et al. Followed 224 patients with acute cholecystitis. 54 of these patients required PCT placement. A little bit over half of them actually underwent elective laparoscopic cholecystectomy at a later date, with a conversion rate to open cholecystectomy of 8%. More recently, 2015, a retrospective analysis of 82 patients who underwent percutaneous cholecystostomy tube placement for acute cholecystitis, 34 eventually underwent laparoscopic cholecystectomy with a mean of 7 weeks between PCT placement and surgery. The conversion rate in this study was significantly higher, it was 32%. So since there are some gaps in the literature without any larger scale studies, the aim of our study was to investigate the rate of subsequent cholecystectomy following PCT placement and identify clinical factors associated with this subsequent procedure. In addition, we also wanted to examine the incidence of CBD injury in laparoscopic cholecystectomy performed after PCT placement. So for this purpose, we use the SPARCS database. For those that don't know SPARCS is an administrative database that collects patient-level information from all patients in New York. So data that is collected is patient characteristics, diagnosis, and treatment from all inpatient, outpatient, also ED visits, and ambulatory procedures in the state of New York. Through the use of ICD-9 and CPT codes, we identified all patients that had PCT placement between 2000 and 2012, and we followed them up to 2014 through the use of a unique identifier, so at least 2 years of follow-up. We excluded patients with age less than 18 years, those with missing information, lost to follow-up, which was significantly, it was 3,700 patients, and in-hospital mortality during the PCT placement, which was 18%. In terms of outcomes, we examined patient demographics, comorbidities, complications, and the rate of CBD injury. We used the univariate analysis to examine the marginal association between patients' characteristics, comorbidities, and complications. And factors that were significant based on univariate analysis were further considered in a multivariable logistic regression model. So from 2000 to 2012, there were 9,738 PCT placements. And from these patients, approximately 31% underwent subsequent cholecystectomy. The top 5 reasons for PCT placements were identified as biliary disease, septicemia, pancreatic disorders, complications of surgical procedures, and acute myocardial infarction. Time to cholecystectomy was 14 weeks, and 17.8% had a subsequent cholecystectomy at a different institution, so it was relatively a low percent. So this table shows the rate of PCT placement per year and also the follow-up of those patients with subsequent cholecystectomy, the numbers of laparoscopic cholecystectomy per year, and also open cholecystectomy per year. And here you can see that PCT placement actually significantly increased from 2000 to 2012, as there were 356 in 2000, and 2012 was 1,232. Also, the rate of subsequent cholecystectomy significantly increased from 25 to 31%, close to 32%. More people were actually performing laparoscopic cholecystectomy, as that rate increased from 11% to 22% from 2000 to 2012, and less people were performing open cholecystectomy or the need for conversion from 13% to 9%. in 2012. So when we compared patients who actually had a subsequent cholecystectomy to those without subsequent cholecystectomy, on univariate analysis, there were differences in terms of age group, gender, race, ethnicity, insurance, and having any comorbidity. Following multivariable logistic regression, younger patients were more likely to actually have subsequent cholecystectomy, male patients, and there was still some difference in terms of race, not insurance, any comorbidity, and any complication. Subsequent cholecystectomy was associated with at least one complication, as 35% actually had a complication at the cholecystectomy. Rate of CBD injury was 1.6%. From previous data, we actually had our rate of CBD injury is 0.8. So this is twice that than previously reported from one of our studies. And mortality in initial visit for PCT placement was 18%, and subsequent cholecystectomy was actually lower, 2.3, but that's pretty high for cholecystectomy. So based on these findings, we concluded that the rate of cholecystectomy following PCT increased during the study period. Surgeons seemed more comfortable performing laparoscopic cholecystectomy after PCT, as we saw the increase from 2000 to 2012. However, the rate of CBD injury in cholecystectomy is higher after PCT compared to that of general population. So caution should be used when performing subsequent cholecystectomy following PCT, as these procedures may be more technically challenging. Thank you.